Let me introduce Dr. Megan Sandel. She's a pediatrician and national expert on health and housing. She's associate director of the GROW Clinic at Boston Medical Center. GROW is an outpatient subspecialty clinic that provides comprehensive services to children referred with a failure to thrive diagnosis. She's also the principal investigator at Children's Health Watch. She's an associate professor of pediatrics at the Boston University School of Medicine, as well as associate professor of environmental health at Boston University School of Public Health. She's the first medical director of the Medical Legal Partnership and pediatric medical director at Boston Healthcare for the Homeless. I'm really looking forward, if you talk about that, I'd really love to learn more about that. She is also the author of numerous peer-reviewed publications and is recipient of multiple NIH grants. And another fun fact, she apparently did her undergraduate degree in Renaissance Studies. I don't know if that'll come up tonight, but please welcome Dr. Megan Sandel.
Good evening. How is everyone tonight? Good? Yeah, great. So thank you so much. I was really honored to be asked to come to Milwaukee. I've been talking with Habitat for a while about coming, and I really wanted to make the most of my stay. So honestly, I've been here since last night. I've spent the day, actually went to an amazing event this morning that Bader Philanthropies put together to talk about how to get different sectors talking to each other. I then went over to the Medical College of Wisconsin, talked to medical students, talked to the Medical College Wisconsin about the work they're doing with the Greater Milwaukee Foundation, and then this evening. So I just want to really thank you guys for having me. I really want to thank the Medical Society for sponsoring this, because it really is, I think, a unique way in which a medical society is stepping into action. And so I have not seen a similar medical society lean in. And I want to particularly call out, guys, $100,000 for a medical society is a huge commitment and is really about putting into action funding that, honestly, if it shows that it's working, is something that then could be put into broader policy contexts. And one thing that I've learned is, uniquely as physicians, we can be unique messengers to policymakers. We're listened to in a lot of ways. I've joked a little bit. I walk around when I go up to policymakers, and I often wear my stethoscope. And I get treated differently because I am a physician. And while we can argue about whether I should have a different, like a more valuable voice by being a physician, I think it's really important to use that voice on behalf of our patients. And I think that in a lot of ways, we really try to do that. And then I'm really hoping to have a conversation tonight. I'm going to present some slides, probably, hopefully about 20, 30 minutes of kind of an overview of talk, and then we'll really open it up to questions. And so if you think of questions as you go, you have index cards, and then you can pass the index cards up, and we'll hopefully have it more as a dialogue. All right, so let's see. We're going to figure this out. There we go. Okay, so if people can see the slide deck, the roadmap for the talk tonight is I'm going to give kind of a conversation around how does housing impact health, and I'm going to describe it in kind of 4 dimensions or 4 walls of way housing impacts health. I'm going to talk about quality, stability, affordability, and location. And I just want to emphasize, the talk today is the same one, essentially, that I'm going to give tomorrow morning at the Children's Hospital when I give grand rounds, because I'm going to try and say to have the same conversation with the public and the housers and the government and the healthcare world, because hopefully by having the same conversation, we can really catalyze change. I'll talk about how we consider like a home to be like a vaccine. It keeps you healthy now and in the future. I'll talk a bit about this concept of population health, which is kind of homes and people, why I kind of love and I hate that term. And then I'll talk about how healthcare can and housing can become partners together. What are ways in which they can exchange value and be able to be funded together? I'll talk about a campaign that my research network, Children's Health Watch, is part of, called Opportunity Starts at Home. And then ultimately, I always end my slide talks with about equity and why equity is really important. So as we think about it, the evidence on housing quality is like centuries old. Like for decades, we have recognized that accidents is really an important part of how housing impacts health. That's both from kids, right? So once you take away motor vehicle accidents, the leading cause of death for children is home-related accidents, drownings, fires, things like that. And then when you look at the elders, right, home falls and other types of housing-related accidents are extremely important. I first got interested in how housing impacted health, honestly, through asthma. I admitted a child to the ICU with asthma, and I was kind of tearing my hair out. Why was this kid here? She normally had well-controlled asthma. And I ended up asking the family kind of a fateful question: what had changed? And the family talked about getting a cat. Any ideas why they got a cat? Mice. They had basically found mouse droppings in the child's bed, and they were really upset about that. They wanted to try and figure out a solution, and so they got a cat because they couldn't get the landlord to basically get rid of the mice. And unfortunately for that family, the child was allergic to cats. And so that was why she ended up in the ICU. And so for me at that moment, kind of really early in my career, I was a pediatric resident training to become a pediatrician. I realized kind of like, oh my God, I can't send this kid home. She's just gonna have another asthma attack. And so I ended up feeling like the prescription I wanted to write was for a healthy home, and that wasn't stocked at the pharmacy at Boston Medical Center where I worked, right? So how do you start to think about ways in which health systems could start to stock that pharmacy to create housing prescriptions for patients? I just want to highlight there's not only just pests like cockroaches and mice, but dampness and chronic mold can be a big problem, and tobacco smoke, right? 86% of the time, if a child is exposed to tobacco smoke, it's in their home. I have to call out lead, right? Lead is still an ongoing issue in our communities, both lead paint, but also lead in water, lead in soil. And then lastly, I think it's really important for us to call out energy costs, that honestly, housing quality often can lead to excessive energy costs, kind of that heat or eat debate, where if you're paying a lot to heat your home, you then have to make other toxic trade-offs. In other parts of the country, it's cool or eat, but this isn't really important to think about. One thing, we make the connection between home quality and physical health. I don't think we make enough of a connection between home quality and mental health. This is a study that was done in 3 cities. It's featured on the How Housing Matters website that the MacArthur Foundation funds. And it basically showed that poor housing quality was the leading indicator for whether or not kids acted out in school, had emotional or behavioral problems at school. And a lot of that traveled through the parents, the stress the parents felt living in a substandard environment, and then how that carried over into how they parented their kids, and then how those kids carried that into the school environment, acted out, and disrupted the classroom for everyone. And so when we talk about housing, I think we need to talk about it not just as physical health, but emotional health. I think we have to talk about it not just as a kid, but as their parents, their grandparents, and not just how that impacts the individual and the family, but also how that impacts the community, everyone that lives there. As we shift, I often will talk about stability as an iceberg. We talk a lot about homelessness, but homelessness is just the part of the iceberg you can see. There's a lot of iceberg below the surface. There's a lot of hidden homeless, people who are housing insecure, people who are doubled up, overcrowded, have difficulty moving frequently. And really the root cause of this is unaffordable housing. We published a research paper in Pediatrics last year, February of 2018, where we looked at 3 forms of housing instability and their impact on caregiver and child health. This is research from Children's Health Watch, which is a research network that I'm a part of based at Boston Medical Center. We collect data on families with young children, kids 0 to 4 years of age, because that's when you're growing the brain that you need for the rest of your life. And we're asking them questions in healthcare settings, pediatric emergency rooms and primary care clinics in 5 cities: Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. And what we end up asking is, we ask questions on 3 areas. In the past year, were you behind on your rent? In the past year, how many places did you live? And if you say 3 or more, it implies you had moved at least twice. And in the past year, were you homeless, or have you a history of homelessness? I think the first thing that shocked us is we interviewed about 22,000 families over 6 years, and we found that 1/3 of them had a form of housing instability. 1 out of 3 of the renter families that we interviewed in these 5 cities in healthcare settings, families with young children, had a form of housing instability, all of which was impacting their health. I think the second thing that was really shocking to us is when we looked at the overlap between these 3 forms of housing instability, there was very little overlap. When you looked at it, if you were positive for one form of housing instability, 86% of the time you were only positive for that one. So while we talk about ending homelessness, we also need to talk about ending multiple moves and behind on rent, because those are distinct groups of people. I think the last kind of really shocking thing was not only was it common, not only was it distinct, but when we looked at the adjusted odds ratios, right, between kind of stable housing and behind on rent, or stable housing and homelessness, stable housing versus multiple moves, I think we knew that families that had the homelessness exposure, right, their kids would be in poor health, their parents would be in poor health and have a lot of depression and food insecurity and energy insecurity and healthcare cost trade-offs, right, not seeking medical care because of fear of cost. What we were shocked by was that the behind on rent group looked like the homeless group. It was just as bad. In fact, in some cases, it was worse. And so in a lot of ways, I think we have to, if we're going to say we're investing in ending homelessness to impact health, we also need to invest in housing stability as well as a way to route to health, because they're just as bad for your health. The last piece, I've talked about quality, stability, affordability, now location. And as we think about this, the map here is just meant to show you the overlap between the black dots and the red neighborhoods. And what that is where these are neighborhoods in New York City where over a 20-year time period, there was concentrated poverty. Over 1/3 of the families that lived in that neighborhood lived below the federal poverty level. I always like to gut check my audience. Do you guys know what federally poverty is, the level for federal poverty in a family of 4? Yeah.
It's based on a study that Molly Oshansky did for the Social Security Administration in 1964, that based on a basic food dietary supplement multiplied by 4.
Yep.
It changes every year. The OMB comes out with the statistic.
Yeah. Do you know what it currently is set at for a family of 4? Any guesses?
About $18,000.
I think it's a little higher. I think it's like 24 now. But the issue is that, exactly right, it's based on a food budget. It's based on a 1964 calculation of when we used to spend 1/3 of our costs on food, but we don't spend 1/3 of our cost on food anymore. We spend like 1/8 of our current budget on food. And so it is grossly inadequate. It's not adjusted for regional costs. So the federal poverty is the same in Alabama as it is in Massachusetts. And we know that obviously housing costs are pretty different.
That's a recent change, because they used to publish one for rural areas and one for urban.
It's true. And so as we think about it, just imagine living in a neighborhood where 1/3 of the people in New York City are living below $24,000 a year, right? So you can imagine the kind of a generation of kids growing up in the neighborhood where almost at least 1/3 of the families around them are barely getting by, right? We translated this a little bit into a Boston map. So for us, this is a map of the city of Boston. What's important in this map is that it's a map of what's called opportunity. And opportunity is something that the Kirwan Institute at Ohio State set out, which is basically an amalgamation of about 17 different factors to come up with 5 categories: very high opportunity, medium opportunity, low opportunity, very low. So the dark red on this map is basically very high opportunities. So in that case, this, ooh, I just broke it. Sorry, guys. All right, thank you. I will not touch it again. So in this map, the very dark red areas are very rich neighborhoods in Boston or in Brookline, Massachusetts. The very low opportunity neighborhoods, the yellow areas, those are places where my patients live from Boston Medical Center in the neighborhoods of, like, say, Roxbury, Dorchester, Mattapan. And so what we did is my colleague, Dr. Renee Boynton-Jarrett at Boston Medical Center, who runs something called the Vital Village Network, she pulled out of the electronic health record blood pressure readings of 3-year-olds. And she pulled them out, and then she classified whether they were above the 95th percentile. They were elevated blood pressures at age 3. And she basically said, let's look at where the density of, like, the prevalence of these blood pressures are. And the larger the yellow circle, what you can see is that the higher the prevalence is in these low opportunity neighborhoods. So this is a biologic factor related to a neighborhood level factor. And so as we think about it, concentrated poverty, lack of opportunity is literally biologically impacting our kids and how they move forward. And so it gets us starting to think about, if we think about trying to do housing, it can't just be individual houses. We have to start thinking on neighborhood levels. We have to start thinking about ways in which we can impact neighborhood level interventions to lift kids out of poverty if we're going to be truly effective. All right, so switching gears, I always like to talk about home acting like a vaccine. So why do we vaccinate? This is kind of public health 101. We tend to vaccinate for personal protection, right? To protect you from getting diseases. But we also do it related to herd immunity, this idea of, like, by everyone in the community being vaccinated, this is going to protect us. This is very timely, as you've heard about a lot of measles outbreaks in other parts of the country. So this is a cartoon that try and explain what herd immunity is. So the cartoon at the top, you can see they're blue people, and blue people are healthy but unimmunized. And what you can see is if a couple people who are infected, red, come into a neighborhood, boom, almost everyone gets sick and has illness. The second cartoon is where you have a community where many people are unimmunized, but you have a couple people who are immunized. If people come in that are sick, boom, still everybody gets sick. I think one of the biggest things for us is the bottom cartoon, where you have most people immunized. You only have a handful of people that are unimmunized. And when you look at it, when people come into that community that are sick, the people who are unimmunized, 2 out of 3 of them still don't get sick. And so as we think about it, that idea of herd immunity protects all of us, not just individuals, but protects everyone in the community from a threat. And I think as we've seen more and more, there are measles outbreaks where herd immunity has broken down. We published this research actually in 2005 where we looked at high-risk families, families that were food insecure, and what was the impact of having a housing subsidy on those food insecure kids. And so what we showed was kids in food insecure families were 2-fold less likely to be underweight, to be stunted in their growth if they had a housing subsidy than similar families that were eligible for that subsidy but not receiving it. So think about that. Food insecurity for young kids is where they potentially have trouble growing. And then what happens is that if you're able to then now protect them with this housing subsidy, they actually are able to grow normally even though they're food insecure. It gives you some immunity, some resilience against it. So why do we think vaccines are such great deals? So many of you may recall chickenpox vaccine is a relatively new vaccine, but we now give it to everyone. Why do we think it's cost effective? And so the research on this is actually kind of unique in the fact that you would think that we would vaccinate kids against chickenpox vaccine to reduce the number of chickenpox cases. Actually, it's not the full story. If you look at healthcare costs alone, it actually costs us $2 for every dollar to avert a case. But if we actually look at it from a societal point of view, for every dollar that you invest in a chickenpox vaccine, you get $5 back societally. What that explains to you is we vaccinate kids against chickenpox, not only to protect them from chickenpox, but mostly to keep their parents at work. That's the underlying thing that actually pays off, is the societal benefit. And I think as we talk about housing and health, we have to talk more and more about the societal benefit of what we're providing when we provide stable, decent, affordable homes. Shifting gears, population health. How many people have heard the term population health? Some. Okay. So I love and hate the term population health. I love it in the sense that it's my sector's way, the healthcare sector, of getting out of the individual patient interaction and thinking on a broader scale, thinking about ways in which we actually are able to impact patients on a group level instead of just individually. The downside is population health subsumes another term called public health, which has been around for like centuries. And so ideally, we would not want to do that. We would want to honor public health. But I think that we have to get our terms kind of right, is that when we talk about individual health, that's the individual. When we talk about population health, we're really, from the healthcare setting, talking about a population attributed to a healthcare system. And then ultimately, we're talking about community health, which is everyone that lives in the community itself. And public health can inform all of those strategies, individual, population, and community health, as we move forward. The other piece that's important about population health is that how we're getting paid in healthcare is changing. We used to get paid much more on a fee-for-service basis. If you got sick, we did a service, we charged a fee. If you got sick again, we did a service, we charged a fee. There was not a ton of, honestly, incentive for us to keep you healthy, because if you got sick again, we just charged you another fee. More and more, we are incentivized to keep you healthy because we're entering into value-based contracts that basically hold us accountable to keeping you healthy. And so as we think about that, one of the things that's important to keep in mind is only a small percentage of people use most of the healthcare dollars. 5% of the healthcare population uses 50% of the dollars. And so when we start to think about that, it becomes really important to reduce healthcare costs by focusing on these high-cost, high-need patients. I think similarly, when we think about the housing world, we tend to think about homelessness and ending homelessness. But we also know from the previous research I just presented, housing instability is really important. And these two worlds collide because oftentimes when you look at the high-cost, high-need patients, guess what? 40% of them are homeless. And so you can do the best case management you want, but if you can't send a visiting nurse to help you manage your diabetes or your congestive heart failure, you're going to continue to come to the emergency department and get hospitalized again. More and more, we've been thinking about this as what are ways in which we can do advancements as a way to show the impact of this. This is research that we published with the Center for Housing Policy around ways in which to look at, honestly, the impact of prenatal homelessness and postnatal homelessness. And what we actually found was even if you house people after they are pregnant and homeless, they still carry forward an advanced risk of fair or poor health, developmental risk, and hospitalizations. So it's really important to prevent homelessness in this group. Similarly, we found that if you become homeless, the longer that you're homeless, the worse off your health are. So we looked at particularly infants, kids 0 to 1 year of age, and if they're homeless more than 6 months of their young life, they're 250% more likely to be in fair or poor health. They're almost 100% more likely to be in developmental delays, and they're about 50% more likely to get hospitalized. So when we translated that into a cost, we think there's $238 million each year just spent on hospitalizing kids 0 to 4 related to being homeless. So how do we start to avert those dollars and use those savings to start to invest into programs? Similarly, if we look at our high-cost, high-need patient, this is research from Boston Medical Center, we looked at 50 of our highest-cost patients, people that cost over $100,000 a year to our health system, and we find that half of them have heart failure, 70% of them have a mental illness, huge percentage, close to 40% have a substance use disorder, and 47% of them are homeless or housing unstable. And so as we think about that, we need to start to do this, not just because it's the right thing to do, but because we're not going to achieve our health goals unless we start to develop housing stability strategies. I think that this is also interesting because from a hospital, we can not only map it to individual patients and groups of patients, but we can map it geographically. So in Boston, we actually said, where do the patients who are high-cost patients, our top actually 2% of people who use 40% of the dollars, where do they live? And it turns out 40% of them live in 5 zip codes. In the 02118, 02119, 02121, 02124, 02125. And so we said we need to start not only targeting them individually and on a population level, we need to start targeting them geographically. And so we started building housing partnerships in those neighborhoods with community development corporations and with other housing partners that are specialized in the homeless, like Pine Street. And so we actually were able to create a housing initiative with $6.5 million from a determination of need program that required us, when we built new towers, to be able to invest in new community health initiatives. And so we created community partnerships, such as with our partner Nuestra Comunidad. They said, you know what, we're building new housing, but we have a first floor that we want a grocery store to occupy. Can you help finance a new grocery store? And we said, yes, we'll give $1 million no-interest loan to a new grocery store. Another housing partner said, we have an elderly population that needs on-site services. We can't get anyone to send a community health worker and a nurse on site. So we said, yes, we will put an on-site community health worker and nurse and show that by putting those people on site, we can reduce healthcare utilization. We've invested in community engagement, ways in which we ask the community. We put $1 million into asking the community, what are your ideas about housing instability? And I'm excited to say 2 other hospitals have matched our dollars. One $1 million, one $750,000. And then we invested in an equity fund called the Healthy Neighborhood Equity Fund to create more affordable housing. All of those are important strategies that we think are going to move forward in how to do housing partnerships. I want to be clear, my hospital, Boston Medical Center, is not becoming a landlord, right? We don't want to become an operator of housing that we house our patients. We want to do partnerships where we invest in partnerships and create ways in which we can evaluate them to potentially make them sustainable over time. Because this pot of money is not forever. We want to be able to look at our investment portfolios and our service dollars in ways that we can be really creative in the future. So one of the things that I was asked to by Habitat is to talk about exchanging value. What are ways in which we can create partnerships? This is an idea that David Erickson at the San Francisco Fed talks about, is can there be a marketplace that actually values health? And so this idea of, I've talked a little bit about the healthcare pain point, right? That we have high cost, high need patients. Let's talk about what's the housing sector's pain point and how can we kind of find a cure to each other's pain points. So the housing sector's pain point is pretty profound, right? They need capital, they need money, right? They need ways in which to build new units, renovate existing housing units, capital to assist in retail on first floors, money to cover resident services, operating subsidies. All of those are really important ways. But what does the housing sector have that's of value, right? you guys have units, and I know there's not enough units, but to an extent there are actually available places that could be talked about, either units that are available with new construction, renovation, at turnover. You guys have a proven method of ending chronic homelessness. You've been really good, particularly in the veteran space, about targeting enough resources, enough dose to respond to the problem. And you guys have really good residential services, not just around monitoring people, but also around these ideas of linking to medical services and wellness, financial coaching, and other types of health are really important. So what does the healthcare sector have that they can bring to the table? Well, we've got money, right? We have a lot of money, but we have different forms of money. We have different forms like things like provider dollars or payer dollars, things that can pay for services on site. We have community benefit dollars. Many hospital systems are not-for-profits, which means that the IRS asks them each year to report what are they doing to benefit the community that they ought to be paying in taxes. Instead, they're bringing to the community in different ways. And then, honestly, most hospital systems and health insurers have investment portfolios. What are ways in which they can start to engage in investments moving forward? We also have political capital, and I think it's really important for us to use our political capital to increase investing in affordable housing. And then we pay for services all the time. We pay for services in case management, community health workers, health and wellness. What are ways in which we can start to think about partnering with the housing sector in this way? So I'm going to throw out a couple of ideas. Some of these are a little controversial, so I'm hoping that people will ask me about them. So some of these may require a fair housing waiver just because we want to make sure that this is fair and how we exchange value. So one idea would be set aside units, right? Are there ways in which you would set aside units if you invested in a project? Those are ways in which you may be able to have units for high utilizers that would get them out of the emergency department and the inpatient units, and then be able to get better investment terms so that you would build more affordable housing units or build them faster. There may be set-aside units for service dollars. You may be able to do things where, again, by providing services on site, you can house your high-cost, high-need patients, you can house your families that are at risk, and then you could be able to help with on-site services that are really hard to fund. Similarly, there may be ways in which you can also do set-aside units for broader types of investments. There may be ways in which you can do development like this, subsidizing a first-floor retail unit or providing a job training thing on site as a way to try and do it. And then there are flex funds. In LA and other cities, they've set aside funds to cover rent for people. And again, pooling those funds for rent can lead to high-risk populations reductions and resident services that benefit everyone in the community. What this looks like in action in Boston, for instance, there's been a focus on infant mortality reduction, really trying to decrease premature births and low birth rates. So they've targeted high-risk moms that are homeless, and they've said, we're going to partner you with the local health department and their maternal child health nursing, providing support, and then the Boston Housing Authority has provided public housing units for these moms. And that has been hugely successful, not just in reducing premature births and low birth rate and infant mortality, but also helping these moms in their life course be able to get jobs and get out of public housing eventually. We have started to estimate what does it cost our economy every 10 years related to unstable housing. And what we found in our research at Children's Health Watch is that we have $111 billion of avoidable costs every 10 years related to the fact that families with children do not have stable homes. About 2/3 of the costs are related to moms and their health, depression costs, fair poor health, other types of costs. And in kids, it's developmental delays and other healthcare utilizations. So people always ask me, like, where's the money for this, Megan? Like, where are you going to find the money? And I'm like, it implies we're not spending money now. When we are completely spending money now and not getting very good outcomes, if there were ways in which we could shift these costs, I think we could be much more efficient in how we produce outcomes. I'll just call out, there's a really amazing coalition called The Opportunity Starts at Home, which Children's Health Watch is part of, where we're really trying to bridge the gap between the health and housing sectors and really try and get more federal investment in this, because the federal government has been decreasing its investment in housing over the years instead of increasing as the need has gotten higher. And for those that want to see more, it's www.opportunityhome.org. And this is my last slide, and I really hope to be able to open it up for conversation moving forward. I like to talk about homes as a route for health equity. And the reason I think that's important is that equality and equity are not the same idea. And so this is my favorite cartoon. I'm just curious, how many people in the audience have seen this cartoon before? All right, a fair number, good. So what I like to say around it is that the equality slide acknowledges that not everyone starts in the same place. So people are different heights, right, is how they represent it. So there's a short person, a medium height person, and a tall person. If you only give everyone one box to stand on, you treat everybody equally, then only the tall person with one box to stand on gets to that apple of opportunity in the tree. The medium height person, the short person, they get closer, but they don't actually get there. If you treat people equitably, which is the other side of the slide, you give the tall person one box, you give the medium height person 2 boxes, you give the short person 3 boxes. When you treat them equitably, they all get that same fair shot in the apple of opportunity. And so one of the tensions with equity is that in order to get that same fair shot, you have to treat them unequally. You have to give some people more. And you have to acknowledge that people didn't get to be different heights by accident. Structural racism and oppression and other systems of redlining and other things have led to people being different heights. And so our ability to treat people equitably is not only the right thing to do, but undoes those systems that are really holding people back. And so are there ways in which we can start to think about equitable development in Milwaukee? What are the routes in which health and housing systems can work together moving forward? And so with that, I'm going to hopefully be able to open up the conversation and talk more. Thank you very much.